Good afternoon, dear network. Welcome to today's session. We have a great session today that we're looking forward to, and we have a good presentation coming in through from the Northern Bloc, and so finally we've got the Northern Bloc coming in and joining us on the ECHO. We're very happy. So we should be able to have projected the QR code for all of us to register our attendance today. I think we may be having an IT problem. We should be able to project that in a little while soon. So today we are having an echo on TB, and the title we'll be looking at is TPT. How are we doing with TPT? And we have got our guest presenter today is Dr. Nancy Kasese Chanda, and she'll give us a little bit more details as she introduces herself today. So I'll just recognize a few of our network currently have connected in. Lundazi, how are you doing? Lundazi, can we hear from you, Lundazi district? Oh, so we have a QR code, so we can go ahead and register.
Okay, not available. Thank you.
Index. Thank you very much, Lundazi. Okay. I wanted to introduce Lusaka Provincial Health Office. Today, Lusaka Provincial Health Office is acting as our central hub. We want to appreciate PhD and team for allowing us to sit in their offices and project from there at the central hub. So I this afternoon, Dr. Smanda, why don't you say hello to the network?
All right, good afternoon, everyone. It's good to see you all on the network. Thank you very much.
Thank you so much, Dr. Smanda. Okay. Kazungula, are you able to hear us? Kazungula, could you just unmute yourself and just say hello to us?
We are able.
Thank you very much.
Hello.
Thank you for joining.
Yes.
All right. Chilenje, First Level Hospital, are you able to unmute yourself and just say hello to us?
Hello, we are connected. Good afternoon.
Thank you very much. Thank you for joining. Okay. Thank you so much. So today, like I was saying, we have a very exciting presentation. We'll be talking about the TB research, and Dr. Nancy Kasese will take us through. I have a co-host with me, Dr. Maureen Swinda, who we're able to host together. And so we'll have to begin our meeting. So we have also experts that have joined us today, and we will be joined by Dr. Linus Mwinga. I'm not sure if he's connected. Is here now? Okay. So I will introduce them as we go along in the discussion. So to start our meeting today, I'm going to invite Madam Nomsa to give us a recap of what we had discussed last week. Nomsa, are you connected?
Yes, please. Good afternoon, everyone. I'm working from home, so I will not unmute my video. I hope you can all hear me. My name is Nomsa. I support the MOH hub in the ECHO program. So, so last week, Dr. Ziambo, are you able to get me?
So we are able to hear you loud and clear.
Oh,
Thank you so much.
all right. So, okay, thank you. So last week's session, we're looking at adolescents and young people living with HIV. And our presenter was Dr. Chungu. This was a very insightful session. So I'll just give a few highlights of what we learned. We began by defining two key terms. So we did define adolescent as individuals that are aged 10 to 19, while the term young people refers to individuals aged between the 10 and 24 years. So one of the key note that came out of the discussion was that we discovered that we do have gaps in the HIV services that are provided for adolescents living with HIV. And this has led to poor prevention of HIV transmission among adolescents. There's also low retention in care and treatment. And we also identified that there was also low viral suppression. And that is why it is important that healthcare workers are cognizant of the need to actually pay attention to adolescents and young people. So some of the key issues that came out was that adolescents and young adulthood stage of development comes with unique, diverse, and challenging issues. And that's why we need healthcare workers to actually respond to these issues. So we also noted that the stage of adolescent HIV actually needs specific interventions that address the adolescents and the young people. So disclosure was one of those key issues. We did learn that disclosure in adolescent is very important as it leads to good treatment outcomes, and it has empowered adolescents to ensure that they are ready for transitioning to for treatment, and also provides good support. We also learned that the young-friendly services and adolescent support groups also help deliver peer-led services, which are more acceptable actually amongst the adolescents. So those were some of the key highlights from last week's session. Thank you so much.
Thank you so much, Nomsa. Those are very insightful summaries from what we discussed last week. So dear network, like I said, as I was going to introduce our panel of experts. So this afternoon, we have Dr. Linus Ninga, who is currently connected, and he will be joining as one of the experts. We also have Dr. Mary Kaguje, as well as Dr. Maureen Simwenda. And thank you so much for joining us, and we appreciate you taking time to be with us on this important discussion today. So we will go right into the discussion, and I'm going to invite Dr. Nancy Kasese to just introduce herself and then to get on with the discussion. Sorry, we will not be able to do our COVID pills today. We will do it next week, Monday. Dr. Kasese?
Good afternoon, everyone. Thank you, Dr. Ziambo. And it's good to be here. I had requested that my slides be shared for me. Thank you. Yeah, so as introduced, my name is Nancy Kasese Chanda. I work with USAID as a clinical advisor in the TB and HIV department. And for the purposes of the presentation today, I do not have any disclosures. We can go to the next slide.
So are you able to see the presentation, Dr.?
Yes, I can see it now. Thank you. So our session for this afternoon, we are going to look at reviewing the evidence base for TPT implementation. Why do we do TPT implementation? And then we are also going to talk about the TPT Surge Initiative in Zambia. We will all know what this Surge Initiative is, what's going on in Zambia. Then the third objective is we're going to talk about how can we prepare sites, meaning the clinic facilities, how can they be prepared in order to do TPT implementation? And then we are also going to talk about the next steps in the TPT surge, which has begun in Zambia. Next slide.
All right, thank you so much. We'll go into the poll questions. And so we're going to invite the network to participate in this section. And so the moment the polls come, we should feel free to post and poll the questions. So here what we have is, regarding TPT, which of the following are true statements? Regarding TPT, which of the following are true statements? So we have A, TB is the leading cause of death for people living with HIV. B, studies have shown that TPT works synergistically with ART to reduce TB morbidity and incidence among people living with HIV. Studies have shown TPT to be independently reduce mortality. D, screening for side effects before and during treatment cannot mitigate hepatotoxicity. Then E, A, B, and C are true. F, all of the above are true. So inviting you all to begin polling and picking which one is the best answer. Which one is the best answer? We have got 157 people participating. Most of them think that A is the correct answer, is the best answer. So here saying TB, so regarding TB, which of the following is a true statement? So which statement here is true? A, is it A, B? Studies have shown TPT to be independently reduce mortality. C, screening for side effects before and necessity. Then D, A, B, C are true. Then E, all the above are true. So you've got quite a distribution, Dr. Kasese, amongst for this whole question. We'll see how it goes as you continue giving the didactic. So I will end the poll, and then we can move. I'll share and see how we have voted. So most people think A is the true statement, while a few think that it's all of them. Okay, so Dr. Kasese, you may move on to the next.
Thanks, Chair. We can move on to the next slide. Thank you. Okay, thank you very much. So this is basically a review. I'm aware that we've had a presentation on this before, so we're revising this. And as we know, TB is the leading cause of death for people living with HIV. And in Zambia specifically, in 2018, 14,000 deaths in people living with HIV were attributed to TB. And there have been multiple studies that have shown that TB preventive therapy, or TPT, works synergistically with ARVs to reduce TB morbidity and incidence among people living with HIV. There have been other studies, the Temprano study, which I'll talk about briefly in the next slide, that has been shown to independently reduce mortality. Further, we also know from studies that have been done that TPT does not lead to increased resistance. This was from the Tibela TB study in South Africa, as well as some meta-analysis that were done. I have referenced these studies on the last slide so people can go there and look. Further, we know that screening for side effects before and during treatment can actually mitigate hepatotoxicity. That's why we're encouraging ourselves to be sure that we screen patients before they start, as well as during the treatment. And then finally, the point I'd like to make is that TB prevention is key to ending the TB epidemic and reducing economic costs. Next slide, please. Thank you. Yeah, so I'd just like to talk briefly about the Temprano study that was done in around about 2008 to 2015, just comparing patients. About 2,000 patients were enrolled, and some were put on, it was a randomized controlled trial, some were put on IPT and others not on IPT. So we can see a blue line. The blue line on the graph is showing those patients who did not receive IPT, that's isoniazid preventive therapy, and the red line shows those that received IPT, and this was, they were being followed up for cumulative probability of death. We can see the blue line with no IPT was higher, and actually as the studies were done, those patients that received IPT had 37% reduction in mortality at 6 years. So this study actually has given a lot of evidence to the scientific world to say that we need to be giving IPT. And like I said, this is a review. We've already looked at this information before, I'm aware, but this was just a revision of what is the evidence that we have in the scientific world that TPT works. It reduces morbidity and mortality, and it reduces costs. Thank you.
Thank you so much, Dr. Kasese. We will move on to the next and share share another poll. We're inviting you to participate in sharing in this one. So this one is saying, which groups of people is TPT recommended for in Zambia? Choose the best answer. Adults and adolescents living with HIV, children less than 1 year living with HIV, children more than 1 year living with HIV, patients receiving chemotherapy. E, all of the above. F, A, C, and D are true. So which one here is the best answer? So which one is the best answer? Which groups of people is TPT recommended for in Zambia? Is it adults or adolescents living with HIV? Children less than 1 year living with HIV? Children more than 1 year living with HIV? Patients receiving chemotherapy? Or all of the above? So we only have about just less than half people who have voted so far. We're looking for more people to vote. It is very important so that we can learn our practices at the moment. Okay, Dr. Kasese, you can see how interesting the answers are. They've evened out, almost similar. Okay, so I will be ending the poll very soon. Thank you very much for polling. I'll end and then share so that we can see how we have we've voted. So about 38% think that E is the correct answer. Okay. So I'll stop sharing. Now, Dr. Kasese may continue.
Thank you very much, Chair. Yes, interesting answers indeed. So my next slide is taking us through the Ministry of Health Zambia guidelines for the management of latent tuberculosis infection. So, and I'll go straight into the priority groups for TPT according to the Zambian guidelines. Number one, it's adults and adolescents, that's 10 years and over, living with HIV, regardless of immune status, whether they've had TB in the past or the ART status. The second group is infants, that's children aged less than 1 year, living with HIV, who are in contact with a case of TB. I think people are getting the answers now. The third group, the third group is children aged more than 1 year to 10 years, living with HIV, who are unlikely to have TB disease on symptomatic screening. So for the older children with or without history of TB contact, if we see that difference. For the infants, they have to have a history of contact of TB, but for the older children, whether they have history or not, we still offer them TPT as long as they screen negative for active TB. The fourth group is HIV negative children aged less than 5 years who are household contacts of people with bacteriologically confirmed pulmonary TB. Then we have other HIV negative groups at risk. These are minors and ex-minors with silicosis, close and household contacts of bacteriologically confirmed pulmonary TB patients, patients receiving immunosuppressive treatment, which includes chemotherapy, and those patients with chronic kidney disease and undernourished individuals. We have another group that I am very careful to mention, healthcare workers who meet the criteria of having additional risks. And Chair, this is because healthcare workers don't want to get TPT, but we are a priority group according to the Zambian guidelines. Next slide, please. Thank you very much. I'll just move on and talk about TPT implementation in Zambia. So we know, I think a lot of us know that we have been implementing TB preventive therapy for some time now, knowing that one of our veteran physicians, Dr. Alwin Mwinga and others, found evidence that INH actually works to prevent TB. But the implementation was slow before 2017. What we've seen in the last 1 year is an exponential increase in the way TPT implementation is being done. And we've noted the following contributing factors. There's been great political will from the highest officers. We have seen a pragmatic approach that has been taken by the TB program and the HIV programs coming together and saying, let's fight TB in Zambia. We cannot eliminate TB if we have latent infection in the community. We've also seen an increase in procurement of commodities, mainly the drugs, that's INH and B6 with PEPFAR support. Another thing that has led to this increase in TPT uptake is the dissemination of guidelines. So first of all, the guidelines were revised to include all people living with HIV. Previously, it was just newly enrolled in HIV that were eligible for TPT, but now it's everybody who's living with HIV. And then we've also included other risk groups, and we've given alternative shorter regimens in the guidelines. So the 3 HP, that's rifampicin with isoniazid for 3 months, as well as rifampicin and isoniazid for 4 months. The TPT implementation in Zambia right now, how we're doing it is that the main priority groups are the people living with HIV and children under 5. I just wanted to highlight the difference. In 2018, 18,000 people completed TB preventive therapy course. And in 2019, you see the exponential increase there of 110,000 people completed TPT course. And going forward, we have really huge targets. We would like to have all the eligible people living with HIV, about 85%. We estimate that to be about 85% of all the people that are enrolled on ART. They should receive TPT by the end of 2020.
All right, thank you so much. Indeed, it's important that the healthcare workers know that the priority group for receiving TPT. Thank you for highlighting that. So we move on to our third poll, and I just will share it. So this one is saying the following were some of the best practices from the Pathfinder, except, is this the correct one?
Chair, I think the poll is incorrect. It's not the correct one.
Yeah, this one is not the correct one. We seem to have entered a different poll. Let me just check. All right, I think that will be all for now. This poll wasn't registered as we had thought it was. So sorry to the network. We'll just proceed with the presentation from Dr. Kasese. I think you can pick it up from here.
Thank you, Chair. But we can have that poll at the end, can we? The poll question.
The poll, we may not be able to poll it, but we can still discuss it at the end.
All right.
Chair, the previous poll might be needed to be put back because it speaks to the slide where she's going now.
Okay. It's just that we might not be having an opportunity to poll as a network. So, but we can go through it. So what are some effective ways to improve TPT implementation? A, assure drug commodity stock security. B, provide IPT registers. C, report and manage adverse events. D, all of the above. So perhaps I'll just ask the network to take note of this, and then you can pick your answer, but may not be able to poll because the poll entered is not the correct one. So maybe just take note of your answer. We'll discuss it at the end of this session. So what are some of the effective ways to improve TPT implementation? Assure drug commodity stock security, provide IPT registers, report and manage adverse events, all of the above. I see people already putting polling on the chat box. That's great initiative. Thank you so much. I think we'll take note of that, but we'll ask Dr. Kasese to move on to the next slide. Thank you.
Thank you very much, Chair. So we can go to my next slide, please. Can't see the slides. Okay, great. Thank you very much. I'm going to talk about what we did in Zambia, what's been going on as far as the TPT surge. So as the word surge implies itself, this is a powerful forward movement. So we know we've been implementing TPT, but we've not been moving quick enough. So that's why the surge is just meant to push us a bit further to ensure that all the eligible people living with HIV receive TPT. The Permanent Secretary of Health declared TPT as the fourth 95 for Zambia's HIV fight. For those that attended the HIV conference in December 2019, this is one of the statements that the PS made. And so as a program, this really gave a lot of impetus to people to move forward and say, let's do as what the PS has directed. And implementation of the TPT surge started in February 2020 with 24 Pathfinder sites. These were selected from all the 10 provinces. And the Pathfinder sites were really meant to give us lessons. What are the best things that we can do to improve TPT surge? What are some of the challenges and how do we solve them so that they can help the whole country to know how to move forward with the TPT surge? So the Pathfinder sites are like, we haven't really started. We're just looking to learn lessons. And now we are ready to have the real surge go forward. Next slide. The surge site activation. So these are the things that we put in place to make sure that our sites were ready, and this is definitely what needs to be done. We need to determine the eligible clients and then set targets. So to determine eligibility, we all know how do you determine eligibility for TPT. First of all, you have to screen for active TB. Make sure that this person in front of you does not have active TB before you consider them for TPT. And once that has been done, then you determine, are they a priority group for TPT? Then you determine, have they received TPT in the last 3 years? Do they have any contraindications? And that's when you set your targets at the site level. So this is site level activation. And then still at the site level, we have to make sure that we have 6 months supply of INH and B6 for all the people that are eligible after we've set our targets. And then other activities included orienting healthcare workers to these same search procedures which we're talking about, to the guidelines, the new guidelines, the clinical algorithms, just to make sure that people are screening adequately and properly. And then also we had to orient healthcare workers to the new TPT register and the M&E framework for weekly reporting. We have a weekly reporting framework that we're using for just as we started off doing the Pathfinder sites, because we needed to be quickly learning lessons and applying them. So this was being done weekly. And we also included adverse events reporting, because when patients are having adverse events and they're not being reported, they're not being managed, we might just find the patient staying away without knowing why. So this was one important factor in the search site activation. The next thing, and probably one of the most important things, is to conduct a site-driven assessment of barriers. So we know that there are different ways in which patient flows are done in different facilities. So it's important to assess the patient flow at every specific site to see where are the gaps, where are the patients being lost. One of the things for sure that we found out from DQAs, from site visits, is that there are more patients who are receiving TB preventive therapy than are being recorded and reported. So we need at the site level to assess and see why are patients not being recorded, where's the place where we're losing these patients, and make sure that we put in measures to capture everyone that has received TPT. We also developed a plan for identifying clients that have not yet received TPT. One of the things that worked very well is actually found that they did not that they had not yet received TPT, they were eligible, they put a sticker just to alert the clinician, the next person who will be seeing them, that this person needs to receive TPT. And then also establish a patient flow with staff responsibility for assessing TPT uptake. As far as demand creation, in the surge sites, the community component of demand creation was done, restricted to within the facilities, just because we did not want to, blow it up if you go on TV or radio, when we do not have adequate INH and B6, and then also we have a very specific community that we're looking at. It's the people who are taking ART. Thank you. Who should participate in the surge? Everybody should participate in the IPT surge, the TPT surge. People from ART, from the TB clinics, pharmacists to assure the drugs, data entry clerks, as we've heard, we need to capture the district focal persons, community health workers and volunteers, the provincial and national level TB and HIV program officers also are very important because they're providing us with the policy guidance, they're ensuring that the drugs will be available. So everybody should participate in the TPT surge. Next slide. I'd like to share some results of the Pathfinder sites. So we had 24 Pathfinder sites, and as of June, these are the results. We do not have the July results, they're still being compiled. But this is just an example to show you from week 1, which was February when we started the TPT surge, up to week 7, which was March. You can see that's nice upward trend of TPT initiations. When we hit COVID at the end of March, we see, we see the numbers going down. But in May, there's something that happened that we've been able to review this, review the data coming from the sites, and just having engaged the TPT sites to say what can we do. So you see that we start to come up a little bit, but not yet reaching the numbers that we had before COVID. It's important that we go back to those numbers, that everybody who is eligible needs to get onto TPT. Thank you for that. Next slide. This slide is just showing us the performance of these 24 sites. And it's basically just to show us that we will be monitoring the sites. We want to see who is doing very well. Like the highest performing site in June was, was Mwanjuni Health Post. This is in Central Province. And it's important for us to learn lessons from Mwanjuni and ask them, what have you done? How come you've reached 82%? While other sites, particularly Kasama, they were still doing, performing quite slowly. They are less than 10% achievement against the target. Thank you, Chair. Next slide, please. Okay, so just to summarize the lessons that we learned from the Pathfinder sites, the best practices. If you accurately determine the eligible people, the number of eligible that need to receive TPT. And this is very important because, as I said, we have been implementing TPT for some time now. There are some patients that have received. So you need to accurately determine and say who is due, so that you know if we have a number 5,000 that we need to put on, we quickly move on with it. If we reach saturation, we would move from the Pathfinder site instead of moving blindly. The use of the color-coded stickers to flag the eligible, that's very important. Once we know who's eligible, just color code, tell the next person who will see them. The provision of R&R tools, that's recording and reporting tools. As I mentioned earlier, we found that we're not reporting all the patients that are receiving TPT. Sometimes it's an issue of not having the registers. And then also just going through the records to ensure that the records are completed and they're also reporting timely. And one final thing that was very, very helpful is to align the TB preventive therapy schedule with ART. Remember, all these patients are people who are enrolled on ART. So if they're coming for ART in 6 months' time, and then we give them TPT for a month, some of them had problems with that. So we had to align where it was possible. And you can see the challenges. Then for next steps, what do we want to do next? Is we have to share these best practices like we are doing now, and in other fora, please make sure that we share these best practices so people are able to know what they can do to improve TPT implementation. There was one challenge we found whereby Smart Care is not able to run reports for TPT, like to tell us who has completed TPT. So that has been a problem, and we need to engage Broadreach. We've started this discussion. We have to select now the phase 1 sites to start working in. Like I said, what we've been doing is Pathfinder sites, just learning lessons. Now we need to go full throttle, select the sites where we're going to work in. When we saturate, we move to the next site. And we have to make sure that we have drugs, the 6-month drugs for all the eligible. All facilities should adopt best practices. Even if you are not selected as a site, phase 1 site or phase 2, whatever, but the fact that you are offering TPT, you should use the best practices and must also ensure patient tracking. We should follow up our patients to ensure course completion. In summary, TPT is an effective way to prevent TB morbidity and mortality in people living with HIV. And TPT uptake can be improved by focused staff orientation, the drug stock management, data management, and patient education. We began a nationwide TPT surge in February 2020, and we're ready to go full throttle now. And all health facilities should engage in the best practices that we've discussed this afternoon so that we can have improved patient outcomes, which is the benefit of TPT. Thank you, Chair. And we have those references there. People can go to them and find out more information.
Hey, thank you so much, Dr. Kasese. This has been so informative to us, and I like the emphasis that you've made in the steps, next steps on how we are all going to really surge up in terms of improving our TPT, administering to all those that are eligible. Thank you very much. I'm sure now we have got a lot of questions coming in from the network. Before we go through the poll questions, maybe I can allow 1 or 2 questions from the network, and then I'll ask also the Mansa team, the team to prepare themselves for the case that they'll be sharing. And that is Dr. Jose Nsulu from Senama Hospital, Mansa in Wapula, is going to share something. So any questions from the network? Dr. Nancy Chanda is here, and she will be able to respond and give us some responses. Any questions from the network? I think you were very loud and clear, Dr. Kasese.
Thank you, Chair.
Okay. All right. So I guess we'll move on to the poll questions. We'll do the poll questions, and then I'll invite you, Dr. Kasese, just to emphasize some of these poll questions so that they can be also great learning points. So poll question number 1. Let me just share so that. Okay, so the poll question number 1 says, the following are some of the best practices. Sorry, this is not the one. Okay, apologies for that. Here is a question, poll question number 1. So regarding TPT, which of the following are true statements? TB is the leading cause of death for people living with HIV. Studies have shown that TPT works synergistically with ART to reduce TB comorbidity and incidence among people living with HIV. Studies have shown that TPT is independently reduce mortality. Screening for side effects before and during treatment cannot mitigate hepatotoxicity. A, B, and C are true. All of the above are true. Okay, so we only have about 18 people that are coding. Feel free to call in. So which one of the statements are true? Which of the statements are true? Okay. All right. Thank you very much. I will have to end the poll here, and then I'll invite Dr. Kasese just to run us through which one is the correct answer. Dr. Kasese.
Thank you very much, Chair. I think I noticed something about the way the questions were written. I think it caused a bit of confusion to the people on the panel.
Okay.
So TB is the leading cause of death for people living with HIV. This was A. So A is true. TB is the leading cause of death for people living with HIV. A is true. Then B was studies have shown that TPT works synergistically with ART to reduce TB morbidity and incidence among PLHIV. That's also a true statement. That's B.
But this one says dependently.
No, sorry. I'm reading the same, I'm reading what is appearing as A.
Oh, okay.
What is appearing as A is actually supposed to be two questions.
I see. So it's like the, sorry, I think we had a technical problem with the uploading of the polls, because I think the polls that were uploaded were a bit different from what we are projecting here. So I think that may have confused a lot of our participants. I do agree with you. I think why don't we just run through the poll questions that are on the presentation. Perhaps that would be much more helpful. So you can go ahead from this one.
Thank you. So please choose the best answer. Regarding TPT, TB is the leading cause of death for people living with HIV. That's a true statement. B, studies have shown that TPT works synergistically with ART to reduce TB morbidity and incidence among PLHIV. That's a true statement. True. C, studies have shown that TPT independently reduce mortality. Studies have shown TPT to independently reduce mortality. That's also true. Then D, screening for side effects before and during treatment cannot mitigate hepatotoxicity. So the best answer is E, A, B, and C. TB is the leading cause of death, and TPT works synergistically with ART, as well as TPT independently reduces mortality. So the best answer is E, and then F is false because D is not correct. When we screen for side effects, we can mitigate hepatotoxicity.
Okay, thank you so much. I think go ahead and read the next one and run us through. Well, unfortunately, network will not move to the electronic polling system. I think we didn't load it up very well, and so it is very misleading. So let's just go through the poll questions like this. Yes, you can run us through this, Dr. Kasese.
Thank you very much. So poll question 2, which groups of people is TPT recommended for in Zambia? Choose the best answer. So according to our guidelines, adults and adolescents living with HIV, as long as they've screened negative for active TB disease. So A is correct. B is also true. Children under 1 year living with HIV, if they have a contact with a TB
I
patient.
noticed most people didn't pick this one.
Yeah, and I know that's why I'm actually even highlighted it, because we need to know that those children, even if they're less than 1 year, if they have history of TB contact, they need to be put on TPT if they screen negative for active TB.
Very true.
Yeah, and then children over 1 year also are eligible for TPT if they screen negative for active TB disease. Then, of course, patients receiving chemotherapy also need to receive, they are eligible for TPT. So the answer is E, all of the above.
Okay, thank you very much. The final question.
Okay, so the final question. The following were some of the best practices from the Pathfinder sites, except, so the best practices as we discussed were A, accurate number eligible determined, that is correct. B, use of color-coded stickers to flag the eligible, that is correct. C, community radio programs on TPT, that one is not correct. Because we did not go into the community to do radio programs, we focused only on our patients that are within the clinics. D is provide the reporting and recording tools, this is correct. E was complete records and report timely, that is correct. And F was align the TPT schedule with the ART schedule, that is also correct.
So the one that is not correct, and that is particularly for this answer, is D. I mean, is C.
It's C, community radio programs on TPT. We did not do this in the Pathfinder sites. We are sticking to the people who are enrolled in ART. We only provided patient education.
Okay. Thank you so much, Dr. Kasese, and apologies once more to the network for leaving you out on this one, and we didn't participate in the polling. I think we had a bit of a problem when loading the polls. There seems to be a mismatch with what we are projecting. So for now, I see that there's still no questions. I'll ask Nomsa, can you please share the slides as Dr. Sulu and team from Northern Province, Senama Hospital, come on board to share this presentation. Very, very, very exciting presentation. Dr. Sulu?
Good afternoon, Chair. Good afternoon, Doctor.
Good afternoon. Good afternoon. Thank you for joining us, Wapula. We are very happy to have you on board.
Thank you very much, Chair. Next slide.
Please go ahead and begin your presentation.
Please, I'm presenting a clinical case which we're following in Mansa. Thank you. So this patient, we've been following her from 2005, but these are the latest or the last review, which we did in March, on 18th March 2020. On 18th March 2020, this client, she's currently 57 years. She has no complaints. In the history, there is no TB contact, there is no hypertension, there is nothing. This client has never received IPT. We screened her for TB. There is no night sweat, there is no weakness. The appetite is good. There is no loss of weight, no cough, nothing. What we need to note is just in her socioeconomic history, she reported a good adherence. The first husband died of HIV. She got remarried. The current husband also is also HIV positive. She's a mother of a daughter who is HIV negative. Only that the first son, this daughter is the second born. The first born died before the age of 15. We never did the HIV test to that son sometime back in the 90s. The HIV test was not done to the son. What we need to note also is that the high educational level, she did tertiary, she went up to tertiary education, she's working. Under physical examination, the general condition is fair. There's no pallor, there's no jaundice, no cyanosis. The weight is now at 80. We are going to see somewhere there how she's been increasing in weight. Unfortunately, we didn't check the BMI, but if we look at her BMI, she should be below 30. Yeah, the respiratory system is clear. The cardiovascular, nothing special. And the abdomen is just okay, there's no tenderness. Next slide. Yes, you wanted just to see how we've been following up our clients. If we see she was tested in March 2005, although it's not recorded here, but on 19th April 2005, this was her CD4 count, 230. Then her liver enzymes, they were normal. Creatinine was normal. Also, by then she was started on metramine 40, which is D4T, but 40 milligrams, 3TC, and nevirapine. As we can see, the progress on the CD4 count has been improving. The CD4 count has been increasing steadily. Okay, if we see the liver enzymes, they are okay, normal. Since we started treatment up to 2019, unfortunately, I ordered new results, but as she's not present in the city, this is why we didn't collect the new results. Your creatinine is just been okay. We can see even the viral load, as we checked in 2018, it was undetectable. We can say 30 copies per microliter. Then, if we see the progress of the treatment, she was first on D40. As we can remember some time back, D40 was phased out. All patients were transitioned, were changed from D4T40 to D4T30 plus lamivudine and nevirapine. That was in 2007, and she continued on it up to 2012. Then later on, when Truvada came on the scene, we changed her from triamine 32 to TDF, 3TC, and efavirenz. That was in 2013. If we remember, triamine was phased out because of side effects, mainly the peripheral neuropathies, which were just too much. So it was phased out. This is how many clients were on triamine 30 were transitioned to TDF, 3TC, and efavirenz. For her, it was in 2013. So she continued with the same. Maybe the question will come, why was she not transitioned last year or early this year to TDF, 3TC, and dolutegravir? She followed me, we discussed. She said she was very much comfortable to continue with this Atripla instead of going to the regimen with dolutegravir. She refused to start that regimen. But luckily, even patients who are transitioned to the regimen of dolutegravir, later on they were reverse transitioned again to this TDF, 3TC, and efavirenz. This is how she's continuing on the same treatment. Next slide. Yeah, so this is the now we have some few questions. What can we do to screen patients for TB and place them on TPT? As we say, our client had taken any TPT. That is the first question. The second question, we may need to know, do we need to wait for the latest viral load and CD4 count results for the client to be eligible for TPT? I'm sure we've seen the eligibility criteria therefore starting TPT. Sorry, it's like it's the network. You can't see the slide here.
So, Nomsa, can we have the slide back?
Yes, please. The last one. Yes, and the last question is to say, what actions can we take for the close contacts? Are they eligible for TPT? Those are few questions which we would like to answer together. I submit, Chair. Thank you.
Thank you. Very good, clear presentation. I don't think it will invite a lot of clarification questions, but I'll still give an opportunity to the network if they've got any clarification questions that you'd like to make at the moment. Otherwise, I'll ask IT to begin preparing our breakout sessions, and then I'll also invite Dr. Smwinda, who's the co-host, who's supposed to pick this one up and just take us through this session. Dr. Smwinda. Dr. Smwinda, are you on the call?
Hello?
Okay, are there any questions? Oh,
Hello?
hi. Hi, Dr.
Sorry,
Smwinda.
I think it's my network. I kept on like trying to get in. I wasn't able to. So I think my network was actually bad. It's actually telling me that. I don't know whether it's your network or mine, but it's low. Yes.
Oh, okay. I see. All right. So you'll be able to pick this one up so that you can just share onwards.
Okay, so we're at the point of starting, sorry, we're at the point of breaking into, going to the breakaway rooms. I hope all the clarifications were made. If at all you have any questions. Hello? Hello?
IT, please mute them.
Okay, so hello? I don't know whether you're able to get me.
Yes, we can hear you, Dr. Maureen. Just proceed.
Okay, if at all, whether any clarification or not that need to be made before we go into our breakout our room, I think any clarification on the case that has been made, you're welcome to ask if at all there are any.
I don't see any hands raised so far.
I don't either. Looks like a really straightforward question. Case from Senama Hospital, Mansa, Wapula Province. I think they did a very good history taking. They noted everything in the complaints, especially on TB, screening, both the physical examination and the history taking. Probably that's why we don't have any concerns from this case. So if there are not any, then we can go into the breakout rooms. I think we should strictly take, is it 15 minutes, 10 to 15 minutes in the breakout rooms. We encourage that you participate in the breakout rooms. The other breakout room will be led by Dr. Ziambu. Just confirm if it's Dr. Kaguje.
Kaguje.
Hello? Is it Dr. Kaguje?
Kaguje.
It's supposed to be Dr. Kaguje, then with Dr. Nyaku, Dr. Linus Mwinga as well is joining one of the
Okay,
groups.
all right.
And then the other groups, you will lead the other one.
Okay, thank you very much. So let's go into the breakout rooms. Thank you.
Good afternoon, everybody. Dr. Nyaku, are you on the call yet? Have you joined yet? Dr. Nyaku?
I'm not seeing Dr. Nyaku, but Dr. Mary, you can proceed. So you can just welcome the network and then you look at the case.
All right. So thank you everybody for joining this breakaway session. So we'll briefly relook at the case and maybe find out from the team if anybody had a question that they were not able to ask earlier. And if there is none, then we'll look at the questions that were raised by the presenter. Any questions that were not raised earlier?
Hello?
Yes,
Wow.
please. So Dr. Simwenda, you've joined us?
Not really. I think I was invited again to join room 1. So we remained in the main room with Linus. I think Linus was supposed to join this room, I think. But we had remained in the main room with quite a number of people actually. Let me see whether I can join another room, the other room.
Is Dr. Linus Mwinga in room 3? Because room 3 is supposed to have Dr. Linus Mwinga and Dr. Seraphine Kaminsa.
So according to the schedule, I'm supposed to be in room 1, which
Room
is
1?
this one.
Room 1 is supposed and we are supposed to, yeah, we are supposed to have Dr. Simwenda and Dr. Kasese, room 1.
In room 1, yes.
Nyaku Kandiwo and Dr. Kaguji. Room 3, Dr. Mwinga and Dr. Kaminsa. Now, I don't know, maybe we just need to proceed.
I think let us go ahead and proceed. I'm just worried, Dr. Kaguja, if I told there's someone in room 1, you may need to probably log out and see whether you go back to the main room or in room 1 so that you can provide the guidance in room 1.
Okay, sure. So Wedi, okay, so I'll log out of this session and see if maybe I can be redirected. I'm supposed to be in room 2 with Dr. Nyaku. All right.
Okay, all right. Okay,
right.
Great.
Can
So
we do something about that?
Yeah. Okay, so we have 3 questions with us here. I think we did go through the questions. The first question is, what can we do to adequately screen patients for TB and place them on or initiate them on TPT? We invite everyone to discuss. This is an open discussion.
Thank you very much. So Lwezi has given us a contribution there, that you do not need a CD4 count or a viral load to determine the eligibility for putting someone on TPT. Perhaps just an add-on question would be now, what would be the criteria? Besides them screening negative, what else do we need to consider? Screening negative for TB. I've seen St. Francis, you are with us. St. Francis, would you like to comment?
You can comment. You can explain for the liver issues. Yes, Doc.
Yes, go ahead with your comment.
I'm sure we also need to, on the question of added, we need to check the liver function tests to see throughout hepatitis and other liver infections that could be there.
Thank you very much. That's a very, very good point. We need to look out for contraindications. Remember, our patients on TPT and especially INH can develop hepatotoxicity. Hence, it's very important to monitor them. Any other comments on the first or the third question? Screening adequately? What is adequate screening anyways, in short? Is it just the symptoms? Is there anything else that we may need to do?
Hi,
Hello.
Chair. Hello,
Thank you.
Chair. I have a question.
Sure.
I have a question to our people, to our friends in the field that are actively seeing patients. So what I see a lot of times on the ART forms is, you know, the TB screening portion just like crossed out, just crossed out. And in speaking to patients, sometimes they'll be like, you know, they'll be like, the doctor just asked me, is there anything wrong with you? And I said, no. Then they cross out everything. So my question is, you know, is that adequate screening for TB when you want to initiate somebody on TPT?
Thank you very much, Nancy. We have a question that has been posed to us. I think we have 5 minutes to discuss before we get back to the main session. When we're seeing clients in our ART clinics, do we really screen them, or we just ask them if there's anything wrong and then we cross out everything? No, 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 on that page, all the systems. Gets back to the question, what is adequate screening? What do we need to do to adequately screen our patients for TB?
Dr. Kandio.
Kandio.
Yes, go ahead, Dr. Matua.
Yes, I think that one you should not be screening adequately for TB. You say that you.
Okay, thank you very much, Dr. Judith. Anyone else? I can't see any more hands. Okay. All right, so let's go to the second question. Please feel free to participate and also discuss. Do we need to wait for the latest VL and CD4 count results for the client to be eligible for TPT? Okay, so Mwangata has a hand up again, has his hand up again. So let's see if at all there's someone else and we can come back to you. Okay, no hands. We'll go back to Mwangata. Mwangata, can you please submit your contribution? Please let us all feel free to discuss and contribute. Mwangata.
Thank you very much, Doc. Looking at the way they have presented the case, I don't feel they need to wait for viral load or the CD4 results. This patient is qualified, doesn't have active TB, and they have screened. The patient doesn't have any signs that suggest to have TB, and we haven't recorded anywhere where they have said this person has maybe contraindication or severe side effects of TPT. I think they are good to go and initiate the client on TPT.
Thank you very much for that contribution. Anyone else? Anyone else? Any other contributions?
Hello, can you get me?
Yes, yes, yes.
This is Dr. Kambala. Yes, so on initiating of TPT, there is no need for us to consider a client's VL or a CD4 count. The major things that we have to look at are what the client is presenting with. are there any signs and symptoms of active tuberculosis, such as night sweats, weight loss, fever, any cough? If none of those things are present in a client, whether they have a high viral load or a low viral load, or the CD4 count is not okay or it's okay, depending on your parameters, you can go on and initiate the client on TPT as long as they have no signs and symptoms of active tuberculosis. And in a state where they develop active tuberculosis while on TPT, then you go on and hold on to the TPT and initiate full ATT in such a client. Thank you.
I just wanted to add on, Doc. Dr. Simwanda?
Yes, sorry. I was actually looking for myself. Yes, Dr. Kamisa, you can go ahead. Sorry.
Yes, I think one of the other good findings is on the laboratory results for ALTST, in addition to the fact that the patient has no symptoms suggestive of TB. They have a very good liver ALTST result that's not suggestive of any hepatotoxicity with their current drug regimen. So that's also a very good sign that they're eligible for TPT. Thank you.
Okay, thank you very much, Dr. Kamisa. You're actually one of the experts on this panel. I think it's very good to have your contribution, presence here. On the third question, is on what actions can we take for the close contacts? Are they eligible for TPT? Please, again, feel free to contribute. The contacts.
Maybe just to help everyone, we do have a husband as a contact.
Yes.
And we also have a daughter.
Yes.
So maybe for everyone to remember, the husband is HIV positive, the daughter is HIV negative, just to help the platform.
Yes.
Hello?
Yes, you can go ahead.
Yes. So for the husband who is HIV positive, this one, yes, we will need also to initiate TPT. That is if he has not been on TPT yet or has not been on TB treatment in the last 3 years. Yeah, so if the husband who is HIV positive meets those parameters and this screens negative for TB, then we're going to need to initiate him also on TPT for his own prevention. And then for the daughter, I don't know how old she is, who is HIV negative. Can I get guidance on how old the daughter is?
Unfortunately, go ahead, Dr. Maureen.
I think the daughter should be 15 years. Let me just clarify. Yes. Sorry, no, the daughter, the age is not stated, but the first son died under 15 years old. So the age for the daughter is not. So go ahead and tell us what you wanted to mention, if at all, let's say we knew the age of the daughter.
Maybe just a contribution, a clarification.
Yes.
The daughter is married. She's more than 22, 25 years, somewhere there. She's even at her own home.
So,
thank you.
Okay, so for the daughter who is 25 years old, there is no need for us to go on and initiate TPT. Yes. That's my
But just a
submission.
reminder, I'm sure you are getting somewhere, just a reminder, particularly if at all also we have children, maybe just to mention that we have, there is also a challenge in initiating children on TPT.
Okay.
So it's something that we can actually bring up, and especially when it says contacts or anyone else within the family. So if at all there are children that are HIV positive and that are maybe eligible, we just have to emphasize that we also need to initiate children on TPT. We are concentrating mainly on the adults, just an emphasis. I'm not really related to the case, but just to emphasize on that. Okay, so we have a few seconds. I just wanted to ask, what about the drug regimen? I know that we are looking at TPT. Has anyone noticed this is a stable client, VL undetectable, good CD4 count? And what about the drug regimen?
So currently in Zambia, the drug regimen that we have is isoniazid, which we give for 6 to 9 months. And then together we give with B6. Other regimens that we have is isoniazid with rifampicin that you
Okay, welcome back. Yes, we are back to the main room, Dr. Kozia.
Okay, great, thank you.
Okay, so welcome back. I think, again, even though is it 10 minutes that we have, 10 to 15 minutes, it is actually shorter. And we tend to have more things to discuss. And yet we don't have a lot of time. So these are just discussions that we had in room 1. I think the group in room 1 acknowledged that the team from Senama did a very good job in taking the history, and also they did a good work on this physical examination. But it was noted that there are other things that probably they could have done. Maybe the height, if at all they had the tools to take the height, the BP, and the temperature was not recorded. For the first question on how they can put in more patients on TPT, the group discussed and felt that at each time that a client is visiting the ART clinic, the eligibility should be determined for each and every client. So they should be categorizing of clients, and the eligible clients should actually be noted and put on TPT. I think earlier on, Dr. Kasese mentioned about the tagging system, so that we identify those that are eligible. On the second question, we noted that there's really no need to wait for the CD4 count results and the VL results for us to initiate the client on TPT, as long as the client has been actively and adequately screened for active TB. We can initiate the client on TPT, but we should make sure that we try by all means and expedite the results for VL and CD4 count. On the contact of the patient, we do note that the patient has remarried, and the patient, the husband is HIV positive. So if eligible, the current husband should actually be initiated on TPT as well. Just again on this, if at all there were children, just an emphasis, if at all there were children in this household, again, we can emphasize that if eligible, they could actually have been put on TPT. This is just an emphasis because we're noting that we are concentrating more on the adults that are being put on TPT, and really forgetting and leaving out children on this initiative. So we can go to room 2. Dr. Kamisa, firstly, maybe I go back to room 1. Dr. Kamisa, is there anything that you'd like to add quickly?
I think you've covered everything. I know you were about to talk about the drug regimen just before we concluded, and I know there was a very good indication that the patient is stable and
Yes.
can take the drug regimen for 6 months.
Okay. All right. Thank you very much. Can we go now to room 2, Dr. Kaguje?
Hi.
Yes.
So in room 2, the discussion was similar. Just to emphasize that when screening for TB in children, I think we also need to look at additional symptoms like reduced appetite, reduced playfulness, failure to gain weight or poor weight gain, and of course, contact to a TB case is very important. Additionally, when we're looking at how to ensure that patients are adequately screened before they start TPT, we also mentioned that we need to look out for other contraindications besides TB. And we mentioned that history of psychosis, history of convulsions, alcohol abuse, existing peripheral neuropathy, and some specific concomitant medication are contraindications to initiation of TPT. Then lastly, I think for the last question, we kind of looked at it slightly differently than I think we should. We looked at if our contacts to TB cases, should be initiated on TPT, and we said that, as Dr. Kasese has highlighted, under 5 contacts should be initiated on TPT, and also those above 5 years should be initiated on TPT if they have additional risk factors. That was it from group 2.
All right, then from group 3, I was looking for Dr. Linus Mwinga. I don't know where the IT threw him. So
He was actually in the main room for some time. Okay.
Okay. So we did actually make some contributions as well. In addition to what has been said, what came out, I think, was that was an emphasis on documentation of TB-related interactions. I think this is quite crucial in responding to the first question. The HIV care summary sheet, also the pharmacy sheet, these have got slots and places where they document TB-related interactions. And so if these can be well documented and then well reviewed in good time as we anticipate people that are coming, then we know who needs to be screened so that we're able to catch them, and that there's a deliberate process put in place to capture those that needs to be screened, so that whenever they do come in, they are screened. And then also to have a same place, single place for TPT dispensation to be done in the same place. This also helps in having a good follow-up. And then the contributions towards the rest, I think, are similar as the rest of the other groups. Thank you so much.
Thank you very much, Dr. Ziambo. Thank you very much, Dr. Ziambo. Dr. Mwinga, Dr. Linus Mwinga, and the other experts, are there any contributions that you would like to make, especially to this case?
I think from my end, everything has been addressed. All the contributions that I had, I gave them to the group, and I think Dr. Kaguje has ably addressed them. Over.
Okay, thank you. Thank you very much, Dr. Mwinga. We're looking at the time. We're almost at 16 hours. We would like to go back to Dr. Kasese for the final recommendations from this session. Thank you.
Thank you very much. We had very good discussions in room 2 where I was, but I've also noticed that there were some questions in the chat which we haven't answered, so I just want to address those. There was a question on 3HP, is it available in the country? So 3HP is not yet available in Zambia, in the country, and this has to do with just the global availability. I think we all know that with COVID, it's a new drug, of course, and then with the COVID issues, there have been, some manufacturers have experienced difficulties in being able to just make this available globally. So there's very little around, and we have not managed to get some for our country, though we've quantified for it, and as soon as it's available, we'll be able to get it in Zambia. And the question on IGRA, also they asked about IGRA, whether it's available in Zambia. So maybe I'll leave that to the program. I know that we have not bought it on a large scale. It may be available in a few sites. But it is in our guidelines, as I said, in our group. And if it's available, it's good to actually do an IGRA test so that we know whether somebody has got latent TB. And then the other question that came was a TPT defaulter. Somebody asked about somebody who defaults. What do we do with them? Can we restart? I'm not sure if that was the question. Can we restart the patient? Yeah, so if a patient defaults, we need to really find out what's the reason for defaulting, of course, because if they have poor adherence, there's no need to start them again, to stop again. So we need to address all the factors. And then once we're satisfied, we can restart if the points at which they stopped. So let me put it this way. The total treatment for TPT should not be beyond 9 months. So if they defaulted, for 2 months, it means that you can put them, because when you add 2 months to the 6, it will just be 8 months. But if they defaulted for 3 or more months, for more than 3 months, that makes the total treatment to be more than 9 months. In that case, you need to begin the course again. You need to start the course again, to start counting from day 1 until they finish 6 months. But if they defaulted for a shorter period, then it means you just add the days that they missed so that they complete the 6-month period, not to go beyond 9 months. I hope that's clear. I'm not sure if I explained it well. So for just finally, what I'd like to just emphasize is a focused staff orientation. You know, we need to remind ourselves about what needs to be done for these patients. We had very good discussions in the group where I was, and sometimes we need to have those reorientation of staff so that they can know how to adequately screen patients. We need to remind ourselves of the guidelines, especially that the guidelines were revised less than 2 years ago. We need to go through the screening algorithms so that we are adequately screening. And the site level assessment is very, very important, because we have different challenges in different sites. So we need to, as a group, in every site, we sit down and find out why are we not initiating? If we're initiating, why are we not recording? If we have issues with drug stock management, all those things need to be done. And finally, the patient education is very, very important. Patients need to appreciate why they are going to be given TPT. You know, because you are going to tell a patient, I've screened you and you don't have TB. So now you need to take medication. So, you know, they need to appreciate why they need to take medication when they actually do not have the disease. We need to explain that latent infection to them and to see the benefits. So thank you, Chair, and also to people on the network for the very interesting discussions. Let's go and search TPT. Thank you.
Okay, thank you very much, Dr. Kasese, for those final remarks and recommendations. I think we've had emphasis on what the TPT surge is. I like the way the presentation started on the emphasis on the importance of TPT before we actually went into discussing the surge. Just a reminder again that apart from the SAGE sites, TPT implementation is supposed to continue in the other sites before we go on to the first phase as we roll out the TPT SAGE. Again, another clarification is that well, let's not leave out children. I did mention it earlier. If at all we look at the numbers on the surge, there are less children, and we need also to actually enroll children on TPT. Thank you very much. Dr. Kozia, back to you. Any of the experts, Dr. Kaguje, I don't know whether you have anything else to say. If not, we can go back to Dr. Kozia. It's 16:05.
No additional contributions from me, Dr. Simwenda.
Okay, thank you very much. Thank you very much. Thank you very much, Dr. Simwenda. Thank you very much, Dr. Kasese. Thank you very much, all our experts, Dr. Kaguje, Dr. Linus Mwinga. We really appreciate your support on this session. And I do also want to extend our thanks to the network. You continue to support, your presence here continue to make this such a big thing for us, and we appreciate that we're able to interact and share best practices. At this time, I'm inviting Nomsa to give us any announcements that we are having, if there are any